Hello, peeps. Sorry I haven't really posted in a long time. I'm just gonna wing this. I haven't really. That's right. Yeah, I haven't posted anything in a long time because I've just been busy and yeah, busy with all kinds of stuff. The ADHD is really setting in since I'm on the spot, but I'm gonna try to get a little bit of soft-spoken reading done. Since I need to get some reading done anyway. I have this magazine called Optometric Management, and I'm just going to read a couple pages. I live in a predominantly Mexican neighborhood, so sorry if there's random trucks with Mexican music driving by and there's random noises and things like that. It just comes with the territory. And we all love a little culture. But anyway, I'm using my iPad Pro. Hopefully the mic sounds okay. Hopefully the video is okay. These are supposed to be top of the line for Apple's tablets. I don't know. Studio quality microphone, yada, yada, yada. I don't know what that means for ASMR in terms of standards for what ASMR should sound like. But anyway, so Optometric Management, there is a article called Be the Doctor. All right. Recently, while speaking at a conference, I had an experience that gave me pause, and I think you will find it interesting as well. I began my lecture as I usually do, by sharing the patient's history and then displaying a retinal photo of one eye. I prefer to present cases exactly as they present in clinic. I lost my place. So the audience can step into my shoes and experience the diagnostic process as I did. I asked the audience to take the photo, include it in their notes, and share it with their favorite artificial intelligence AI tool with the prompt, "What is this?" At the end of the lecture, I invited a few attendees to send me their full AI interaction paths so I could review them myself. It was both enlightening and entertaining. As expected, a single photo generated only a list of differentials. As I provided more clinical details to the audience, they in turn fed more information to AI. The additional findings helped narrow the possibilities, and AI offered useful suggestions for further history and testing, along with the thoughtful questions that aided in refining the diagnosis. However, AI never asked the single most critical question in this case, nor did it suggest the correct diagnosis. Only when the key piece of information, the patient's blood pressure, BP, was provided did the picture become clear, and the management plan aligned perfectly. At that point, AI responded, "This is a medical emergency, requiring immediate actions. 1. Emergency medical evaluation. Patient needs hospital admission. 2. Gradual BP reduction. Too rapid can cause stroke slash myocardial infarction." Hopefully I said that right. 3. Systemic workup. It continued, "Was this patient sent to the ER immediately? This BP is life-threatening. Risk of stroke, MI, is it renal, RENAL, renal failure, and aortic dissection." As a speaker and educator, I was relieved that AI ultimately agreed with my presentation. It would have been embarrassing to defend my clinical judgment against it. But as a clinician, I emphasized a vital point to the audience. What AI did not know and did not prompt could have killed this patient. Let me be clear. I embrace technology and the tremendous value it brings to our field. It's bothering me. Cute anyway. There we go. Now I can lean back and relax. Okay. I embrace technology and the tremendous value it brings to our field. At the same time, I am deeply aware of its limitations and gaps. Those gaps are our responsibility as clinicians to recognize and bridge. My concern is that a few impressive cases where AI outperforms human judgment could lead some to lower their guard, delegate too much to AI, and step back from being the doctor. When we do that, when we stop actively questioning, integrating unspoken cues, and exercising clinical intuition, patients will suffer. Oh. Y'all hear that? Love it. Okay. Patients will suffer. AI cannot see what you observe, but do not document. It cannot know what you analyze and deem unnecessary to input, or what you overlook due to time constraints or fatigue. I'm gonna listen, wait. It cannot sense what you and your patient feel, fear, or intuit. Remember, when our parents warned us that relying on calculators would make us forget how to do the math, or that digital clocks would erode our ability to read analog time, those concerns have proved valid, though they are minor compared to outsourcing our critical thinking skills. My plea, reflecting on this story, is far more consequential. You are the doctor, and you are exceptional. You know your patients in ways AI never will. You understand them as people when you take time to ask. You recognize when to keep digging if findings do not add up. You may encounter only a handful of unicorn cases in your career, those that defy the straightforward diagnostic algorithms AI favors, but what if one is life-threatening, as this one was? I have seen many such cases, and until AI can truly feel, fear, and care for our patients as we do, it will remain just a powerful tool to assist us. You are still the doctor, so stay vigilant. Do not let down your guard. Be the doctor your patients need you to be. This is for Dr. Jasper. Dr. Jasper practices in West Palm Beach, Florida. She is an American Academy of Optometry Fellow, Chief Optometric Editor of Optometric Management, and author of Creating Your Business of Distinction, which can be purchased here. Okay, next one. I didn't put any lotions on my hand now, sorry. Kind of interesting. Not really anything. It's kind of interesting. It says, staging and practical management of diabetic retinopathy. Changes in the healthcare landscape reveal an opportunity for an update. Let's do that one. All right. And then it actually has some interesting pictures of retinal photos. This is the back of someone's eye. You can see the retina here, I think. The macula somewhere near here. I'm not a pro at deciphering these pictures. Honestly, I just type them in. Doctor does the rest. Anyway, all right. The correct staging of diabetic retinopathy, DR, is crucial to quantifying the level of pathology, which enables accurate risk assessment for disease progression and when to refer a patient to a retina specialist for treatment consideration. The Diabetic Retinopathy Severity Scale, DRSS, which comes from the Early Treatment Diabetic Retinopathy Study, has been readapted into the International Clinical Diabetic Retinopathy Staging System, which is universally recognized and used widely in clinical practice. Can you see? This ICDR is broken down. Sorry, there we go. More comfortable. Into two main categories: non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy staging, mild NPDR, and recommendation for management. This is characterized by the presence of at least one microaneurysm or retinal hemorrhage. Microaneurysms represent outpouching of the retinal capillary walls due to weakening from parasite loss. Hemorrhages result when the capillary wall ruptures within the internuclear or outer plexiform layer of the retina, therefore forming a characteristic blot appearance. Fluorescein angiography is not indicated at this stage and color photos, while not necessary, are often useful for patient education regarding the importance of complying with their follow-up appointment and monitoring disease progression. These patients should receive a repeat dilated exam in 1 year, because approximately 5 to 10% of these patients' NPDR will worsen in that time. Additionally, as with any stage of retinopathy, communication with the patient's primary care doctor, notifying him or her of the presence of retinopathy and the importance of which angle is my good angle? This one. Let's do this. And the importance of systemic disease management, as that can affect progression, is advised. Moderate NPDR and recommendation for management. This is characterized by an increasing number of microaneurysms and hemorrhages, as well as the emergence of cotton wool spots, venous beading, and intraretinal microvasculature abnormalities, to a mild degree, less than that of severe NPDR. Figure 2. Cotton wool spots are fluffy, while retinal lesions that represent focal ischemia. Venous beading is a localized, irregular, sausage-like dilation of the vein. Intraretinal microvasculature abnormalities represent shunt vessels that are formed due to retinal non-perfusion. They can be distinguished from true neovascularization by the FA in that our IRMAs don't leak dye, but true neovascularization does. These patients should receive a repeat dilated exam within 6 months. As many as 16% of patients who have moderate NPDR progress to PDR within 4 years. Fluorescein angiography is not needed. And that is it, y'all. We're at 12 minutes. Hopefully this will hold y'all over until next time. Have a good night.